Well, good evening, everybody. Welcome back after a short break over the summer. And we're in a situation with regard to COVID-19 that we're in an interim period. And some people might say the quiet right before the storm. But even if there isn't a storm to come, there has, of course, as far as a lot of people feel, been a storm already, and if you're not, a revolution in the world of general practice. And it's a great pleasure to have Ian Goodman to tell us about it and to tell us about what's been going on and what he thinks is going to happen. It's a particular pleasure to have Ian here, not only because, of course, he is the husband of a past president of the London part of the association, and that he's also, I can say that his father was one of the people who for many years tried to persuade me to spend more time in activities in Jewish medical scene. So I've got his father to thank for that, and I hope he feels that I'm doing a good job persuading him to do the same. Yeah.
Thank you, David. Yes, I think you're doing a fantastic job. Thank you very much for inviting me to speak, and thank you to JMA. This is a general talk, really, about what's been happening, particularly what's been happening in my neck of the woods, and what I think is going to happen, how the effects of the pandemic are going to have an important impact on the way general practice sets its stall out for the future. So I'm a GP. I've been a GP in Northwood for 34 years. I'm the chairman of the Hillingdon CCG, and I have the honour of having both Boris Johnson and John McDonnell as my local MPs. They have neighbouring constituencies, which makes life quite interesting as a chairman of the CCG. I've also spent a fair bit of time over the past 30 odd years getting involved in various issues around improving general practice service, and particularly computerization and digitization. So that's what I'm going to talk about tonight. So as you all know, we sort of sleptwalked into the COVID crisis, and when we were in it, life changed. Life as we knew it changed, and will probably not be the same again ever. And as is not unusual in the UK, once we realised the extent, there was a slight panic. I think there was a panic within the acute sector because we were worried about the lack of ITU beds and ventilation units, and a feeling that it might be overwhelmed. But as is often the case in crises in the NHS, everybody rolled up their sleeves. There were a lot of people who volunteered to be redeployed. We had the new mantra, stay home and save the NHS. Clearly this message worked up to a point. The new term, the new life was lockdown, and not everybody in Parliament stayed in lockdown, as you know very well. Business as usual in the NHS stopped. All elective activities were stopped. And in fact, patients voted with their feet, both in the acute sector and also in general practice. But general practice didn't stop. It slowed down, but it still responded to its patients, not just for urgent care and possible cancer referrals, but for routines. And the way we did it was actually extremely interesting and very important. And that's one of the things I'm going to highlight tonight. So the GP's response was really fantastic in terms of the speed at which they changed their practice. They rearranged their surgeries so they could keep patients as safe as possible, having hot zones and cold zones, if you like. There was a massive shift to digital technologies, which I'm obviously going to talk about a bit later. The staff were all risk assessed very quickly, which actually ended up about 20% of staff not being safe to see face-to-face patients, both at the front end and also at the back end of the surgeries. And in northwest London and north central London particularly, every CCG, every borough established a hot hub where patients who were suspected of having COVID could be seen rapidly and assessed. we all know that, that for the first 2 or 3 months, there was a crisis of protective equipment, but GPs again used their own resources to source PPE from all over the place wherever they can get it, including asking patients to develop things like visors and face masks. In some areas, they resorted to having drive-in vaccinations, and in East London in particular, they were doing childhood immunisations at a rate of 1 every 2 minutes in the car. The mind boggles at such a slick operation. And the key was the collaboration and cooperation of neighbouring GPs, of the GP community, and also the willingness to roll up one sleeve and do what was necessary. And the key to the successful adaptation really lies in the fact that GPs are independent contractors. They're not employees of the NHS, they have a contract with them. And this allows much greater flexibility and more independence of approach. And so what we did was we, for all GP surgeries in Northwest London and probably North Central, put in what was called e-consulting front ends, which again I'll talk about in a few minutes. We were already using a lot of digital technology, particularly texting apps. The one in particular that's very popular is called AQRX, but we also use this for remote working, and we use other remote working apps, and we also begged, borrowed as many laptops as we could to be able to work from home, and used remote login software. On top of that, already GPs had been starting to work together in primary care networks. These were set up before the onset of the COVID pandemic. And because they were already set up, it made collaboration and cooperation that much easier and quicker. And one of the most important aspects in terms of patient care was that GPs have the best patient databases in the NHS. They've been computerized universally for at least 20 years. So they've got 20 years of data. And this allowed them to be able to speedily identify those patients most at risk and offer them support. But in addition, CCGs collected and collated GPs' data on a daily basis that enabled them to look at the way the pandemic was spreading in their area and to be able to plan services accordingly across the board. And this is just a snapshot of the data that we collect in Hillingdon every single day. So on the top left, there's a graph of suspected and proven COVID, and the graphs just project along. On the bottom of the graphs, we have some demographic data, age, sex, ethnic minorities, and also comorbidities. And this was collected by every practice in every CCG, certainly in Northwest London, and I expect across the board, and was a very useful tool for looking at how the services could be used, both in the acute sector, what areas to prepare for, which were the hotspots, and which areas were the rates going down. And the other thing about our data, and in Northwest London, we are absolutely unique, is we have what's called the Whole Systems Integrated Care Database. Now, this was set up 4 or 5 years ago. And what it is it's the most comprehensive database of patient care, probably in the world. We collect data from all but 2 practices in Northwest London, and that's about 2.4 million patients. We collect data from acute hospitals, we collect data from community and mental health trusts, and we collect data from social services. And all this data is collated, and then it's fed back to GPs as an integrated care record. It's the only place where you can actually follow patients' care in the different areas, and not just the community and hospital, but also in social services. But also it can be used by CCGs to actually plan services and to identify needy and at-risk groups. So when you go into the database, and you have to have access rights to get into it, you get faced with this front end. And for this presentation, you can see that there's a COVID-19 tab to go into. And if you press the COVID-19 tab, you get, first of all, you get a summary of various aspects of the COVID symptomatology and demographics. And you can break this down by age, gender, ethnicity, whether housebound, etc., frailty, long-term conditions. But more importantly, at a general practice level, you can go into your own practice dashboard and identify individual patients. And so if you look at the top of the slide, just below the mauve banner, you can see that you can break down the patients by what network they are in, what practice they're in, their age band, and where they're being seen at a particular time. So that was the first dashboard that we produced and sent out for access for all our GPs. The second dashboard was the shielded patient dashboard, and all clinicians who were active during the COVID crisis will know about the shielded patients, and this was the term for particularly vulnerable patients who we felt were most at risk of getting complications if they were to succumb to COVID. So again, we can have a summary. You can see on this that we look at the frailty, ethnicity, age bands, whether they got care plans, etc. And again, more importantly, from a practice point of view, and this is data from my own practice, you can identify patients who are most at risk. So again, at the top under the mauve banner, we've focused it onto my practice, which is the E86001 practice, and we can see that there are 617 patients who are shielded. And then if you go into it, it gives you a list. It tells you who they are, where that data came from. Did it come from the NHSD algorithm, or did it come from the whole systems database separately? It tells you why they're shielded. It also gives them a risk rating, a frailty score. And then we can also RAG rate them by other risk factors. So in this slide, you can see they're RAG rated by the number of medications they're on, by how many times they've attended A&E as emergencies, and how many times they've been admitted as emergencies. We can also, at a glance, see whether they've got a carer, whether they've got a care plan, whether they're in supported living, whether they've had a social worker or district nurse, and has that district nurse visited. And we use this to coordinate care right across the borough in Hillingdon, and I'm sure similar systems were used in other boroughs in northwest London. So that gave us quite a bit of support in identifying and supporting the most at-risk patients. But similarly, work as usual, business as usual, had to carry on. And as I pointed out earlier, we were very quick to switch to digital technologies, and in particular, remote monitoring. And again, Hillingdon and central London were at the forefront of setting up what we call virtual wards using digital monitoring. And what we used was an app you could download onto your smartphone called MeadowPad. And this had been supported by NHSX. So as you can see in this slide, you can download the app onto your smartphone, and you can feed in vital data onto it, and then it gets sent automatically to a dashboard at our hot hub. So our hot hub was the center where we sent all the patients we suspected of having COVID, assessing them, making a decision on their care, and if they were staying in the community, we would monitor them. So the process for this was very simple. There was a patient selection for the appropriateness of them to be monitored, and they were given pulse oximeters. A lot of them would have had thermometers and blood pressure machines at home anyway, and we set up a virtual ward. This slide is a bit busy, but basically just look at the top headings and move from left to right. So the patients were referred into the virtual ward, they were onboarded, and they were monitored. They were monitored several times a day. There were daily reviews. The clinicians could look at the dashboard to see whether they were going off, and then at appropriate times, they were discharged. but once they were discharged, a message was sent to the GP on the GP's computer just to keep an eye on these patients. And several of them had to go back onto the virtual ward. Here's an example of one of the patients who we looked after on the virtual ward. She was a 60-year-old lady. She wasn't overweight, she was white, but she had asthma and she had type 2 diabetes. She presented to the GP on the telephone on the 8th day of her symptoms, and her symptoms were mainly respiratory. So the first advice was to increase her asthma inhaler therapy. And then she was sent to the hot hub for further assessment. And for the next 2 days, she appeared to improve, and so was discharged back to her GP. However, by day 14, her symptoms had got worse again. Her cough had got worse. She was getting short of breath. So she was re-reviewed at the hot hub. And even though at the time when she was reviewed, her symptoms didn't seem too bad, the saturations were acceptable, so was her respiratory rate. She was afebrile. She was started on antibiotics, but was entered into the virtual ward using Medopad to monitor her signs. So for the rest of that day, she remained stable. However, the following day, it was clear that her condition had deteriorated. We could monitor her SATs, which had gone down to 89%, and her symptoms had got worse. So we referred her to the local district general hospital, where the chest x-ray supported a diagnosis of COVID, and she was commenced on oral steroids and given supportive oxygen. At no time was she given CPAP or was she ventilated. This carried on for 2 days, and she was sent home to be monitored on the virtual ward and then by the GP. Interestingly enough, when she was admitted, her COVID-19 swab was negative, but her antibodies that were tested later proved to be positive. So, an overview of the first 50 patients that we put into the virtual ward. The demographics are interesting because they're different from the demographics we saw of those patients who were being admitted to hospital and treated for severe COVID, in that there were more females than males. There were a younger generation. However, the ethnic breakdown was worrying. There was a clear overrepresentation of Indian African ethnicity for those patients being monitored. But also, interestingly, the majority of comorbidities were, in fact, respiratory or cardiovascular. Only 10% had diabetes. My own theory for the difference in the demographics is that the patients who were more likely to be severely affected were being admitted at a much earlier rate to hospital. So those patients who were older, who were male, who had type 2 diabetes, they would have been admitted to hospital rather than monitored on the virtual ward. And I've asked the WISIC research team to have a look to see whether that analysis holds true when they look at the data in much greater detail. The feedback from clinicians was universally positive. What they felt they were able to do was recognize these changes earlier, and more interestingly, they got a feel for the pattern in the way the symptoms and the vital signs changed, which gave them much greater confidence in being able to keep the patients at home when necessary and to admit at the earliest opportunity when they felt the signs were going the wrong way. Interestingly enough, we weren't the only people doing this trial. In Watford General, they were discharging patients with respiratory symptoms to monitor at home, and they had similar findings. Equally, the feedback from patients were very positive, as you would expect. They felt much better supported, less anxious about being kept at home while they were ill. But what was interesting is you could see from the data that more patients opted to not use the Medopad app than use it. There were obvious reasons for this. One is they didn't have the technology or the phones, but I also think that they preferred to be phoned and speak to a human rather than have their data automatically transferred and be monitored remotely. But again, that's just my supposition. So the journey so far with our hot hubs looking after COVID in primary care. This is a summary slide. So the dates are we went live on the 21st of April. and these figures are up to the 2nd of August. So the total numbers that were referred via the GP were almost 1,000, and by 111, just over 200. And I think this actually highlights the importance that general practitioners played in the COVID pandemic first wave. Because although the NHSE advice was for patients to phone 111, 111 didn't really cope very well. And there were numbers, hundreds of patients said they couldn't get through, or they were phoned back hours later, and they couldn't wait. Whereas with general practice, they could get through and they could be monitored. And these figures support that quite well. Of those 1,200 odd patients, there were 500 who needed to be followed up. And in terms of the virtual ward, we put just over 200 on them. And so far we've discharged 180. And of those who we're monitoring, 8 on the Medipad arm were sent to A&E, and 16 on the telephone arm were, and there were no deaths in our cohort at all. So that's how some of the things that general practice did to respond to the COVID crisis. And this behaviour change will have important implications for the future of general practice, particularly remote monitoring. There's no doubt that remote monitoring is going to stay, and it will be extended in various ways. So we'll be doing a winter flu monitoring in the same way, not least because in many cases we won't be able to differentiate clinically a patient who has COVID from a patient who has flu unless they're tested. And in either case, they will need to be monitored at home. Similarly, we'll be able to perform remote monitoring on our diabetic patients and many of our other patients with long-term conditions like COPD, asthma, hypertension. Another very important area will be the monitoring remotely of residents of care homes. As you all know, they were particularly badly hit by COVID, and increasingly the various support systems being put in place to look after these residents. And one of the ways is weekly virtual ward rounds, and we will be using various bits of kit to remotely monitor those, give advice, and be able to give a much more comprehensive overview and surveillance of patients in care homes. In addition, being able to use remote monitoring software and equipment will mean that hospitals can discharge their patients earlier to be monitored remotely at home. And this is already being done. I mean, it was done at Watford for respiratory symptoms, and again, it's being done in Hillingdon and up to point at Imperial with their respiratory teams. And remote monitoring will be rolled out in other areas, screening, for instance, atrial fibrillation. But as we see the rapid uptake of miniaturization of hardware, the more sophistication of apps on smartphones, then this is going to be the new norm. So what does this all mean for the future? Well, I've always said that the NHS is the last surviving example of a Soviet-style economy in the Western Hemisphere. After all, it's got command and control, it has 5-year plans, it has capped budgets, and it's always restructuring and reorganizing itself every 5 years or so. And the COVID pandemic has allowed those in power, in the corridors of power of the Department of Health and NHSE, to accelerate the plans they had to reorganize and to restructure. So what's going to happen over the next 6 months? From the administrative point of view, single CCGs are going to be merged into one large CCG per what's called sub-regional area, or STP. So Northwest London will have one CCG, whereas it had 8. North Central will also have one, where I think it had 6. And more locally, there's going to be the establishment of what's called integrated care partnerships. And these are collaborations and partnerships of trusts, acute trusts, mental health community, working with primary care at a borough level, where in theory the various barriers between the silos of care are broken down and care is given by the most appropriate sector of the health organisation. At the coalface of general practice, we'd already started to reorganise before the COVID crisis with the establishment of primary care networks. So a primary care network is a group of neighbouring general practices with a population of a minimum of 30,000 up to 50,000 and sometimes beyond that, who would work together and deliver aspects of care, particularly for elderly care patients and for care home residents. They were established before COVID, as I said, but because they had been established, they worked well during COVID crisis. And over the next year or so, we're going to see these primary care networks really mature and start employing other clinicians and healthcare associated professionals like social prescribers, physiotherapists, first responders, physician assistants, clinical pharmacists, to support the work that's done in general practice and support the work that's coming out of hospital into the community, what's called the out of hospital sector. And as they mature, they will become much more effective, and the opportunities to develop what they do will also expand. So the mutual support and collaboration that such an organisation gives will allow for economies of scale, both in the front end towards the patient-facing side, but also the back office side. We'll be able to offer more accessibility to patients. The surgeries, the face-to-face ones, will be open for longer hours, and the remote consulting will also be working for longer. As they mature, they'll increase their ability to innovate and particularly take on services moved out of hospital. All sorts, not just things like outpatients, but also diagnostics. So what's the focus of our work going to be in the future? Well, clearly, a lot of it won't have changed. We've already been involved increasingly in looking after patients with multiple comorbidities, with long-term conditions. The demographics of the country mean that an increasing amount of our care at time we dedicated to the elderly and the frail, particularly the over 80s, 85s. And what COVID has done it's increased the need for us to improve our expertise with end-of-life care. The way we deliver care to care homes is going to be increased. I've already talked about using virtual consultations and remote monitoring, but we'll be doing much more with care homes in the future. And the other thing that the COVID pandemic has unveiled is the need to address the health inequalities of our population. And interestingly, this is where our whole systems integrated care database really comes to the fore, and we're already using it to identify such patients and then plan proactively how to support them better and to improve their health outcomes. Clearly, with all this increase in work, we need to change some of the ways we work, and one of the important ways is to encourage better self-care, both with the traditional ways of leaflets and pamphlets and mentors, etc., but also with things like smart apps and other new digital technologies. And obviously, we're going to spend a lot of time over the next year or so, probably much longer, giving post-COVID support. So COVID has shown us a possible path forward, and many of you will have heard the new NHS catchphrases of digital first, talk before you walk, e-consult, total triage, remote monitoring I've talked about, and these will be transformed into operational activities. So digital first, for instance, means that the way that patients will access general practice services will change, and the first portal, if you like, place of contact will increasingly be through the practice website. Practices are now discouraging patients to phone for appointments, or certainly to walk in for appointments, but to access the website. And they do this with new software called e-consulting software. And I'll show you an example of this. And this allows them to put their concerns and their requests through this portal to the GPs, and the GPs will respond. A link to this, there's texting software, in particular one called AccuRx, and between these two bits of software, GPs are able to respond much more quickly to patients. And in fact, with most aspects of e-consult software, there's a requirement to make a response within 2 working days, which is a huge improvement on the average of about 2 weeks where it used to be in the older ways of working. Just as importantly, it allows more appropriate prioritization of patient demands, and it's more convenient to the patients because they can get many of their needs met without actually going to the surgery. Before the COVID crisis, over 70% of GP consultations in England were carried out face-to-face. And after that, the figure of face-to-face dropped to around 80%, 20% and 80% were remote consultations. So this is an example of what an e-consult front end looks like. This is our surgery. So patients can either type in the symptoms they're worried about, and it will get them to an appropriate part of our website, which will give them advice, or signpost them to the most appropriate caregiver, or allow them to fill out a questionnaire that will be sent to the GP, and the GP will then respond. And as you can see, the other side is an A to Z list they can click on and get advice. And the top of the list, as you'll see, is if they're worried about coronavirus. So this is just the start of the change in the way that GPs are going to work. Interestingly, the Royal College of GPs in 2018 said quite categorically that they saw that the evolution of a GP role is to evolve into what they call the expert generalist. But able to do this, able to treat increasing numbers of complex patients with multiple morbidities, they will need support, and not just from their local colleagues, but actually increasingly there'll be software support on their systems. So we're already seeing on our GP systems such as decision support software as See the Signs, which is a piece of software produced by Royal Marsden Partners that will nudge GPs and remind GPs of patients who may have symptoms that could be due to early cancer. And not only that, it will then work out a risk that is calculated on their past history and their symptoms, and if appropriate, will fill out a 2-week wait referral pro forma that will get sent via the electronic system to the rapid clinic for cancer in that particular department. Increasingly, there are other bits of software. There's one called Rego that's being rolled out in Northwest London that again prompts GPs to follow the appropriate pathways for as many conditions as have been defined to make sure that all the necessary steps have been taken before the patient's referred. Other organisations like Primary Care Pathways produce templates that sit on GP systems, so GPs are prompted to fill out the right bits and to measure the appropriate vital signs, particularly for chronic conditions, and will give advice coming from the reputable advice centres like NICE. And then, of course, we've had for a long time on our systems things like Q Cancer and Q Risks. And then the digitisation will mean that the boundaries between various silos of care, as I call them, will be blurred. And again, we'll be able to have much more flexible working. And in general practice, that means that many more clinicians and actually administration staff will be able to work from home, which allows for a better work-life balance. And the hope is that this will stop the decline in general practice, perm-physicians in particular, start encouraging GPs to take on partnership roles. And then, of course, what we saw in COVID was the data protection barriers were lowered, and it was much easier to share data and records. And this really was a boon. We're already doing this in Northwest London and in Northeast London with all our renal patients, so that GPs now don't refer patients with chronic kidney disease into a real clinic. They refer to a virtual clinic, and the renal specialist can then access the GP records, go into the GP system, look at the records, and write a virtual consultation for the advice of care for that patient. And that's, by doing that, we've cut down the waiting list for routine renal clinics from 60, 70 days to a week or two. And in East London, I think it's down to 5 days. Increasingly, we can then set up virtual multidisciplinary clinics using software like Zoom or Teams. When there's a shortage of specialists, as we see in Northwest London with endocrinologists or neurologists in particular, then we can have one specialist running an MDT across the whole borough in a project called Project Echo, which both is set up to manage complex patients without them coming to hospital, and also to act as a learning tool for generalists and GPs. There are other bits of software. There's one called the Care Information Exchange, which actually is a piece of patient software that patients can access through their computer or through their smartphone, which sucks in their own patient data from general practice and from hospitals, so they can actually see their own records, and not just from general practice, but from various care organizations. Increasingly, we'll use things like telemedicine, teledermatology, to share important bits of information without having to send the patient to hospital. So that's the way that the GPs are going to change, but also patients' behavior is going to change. So as smartphone technology improves, as ownership of smartphones becomes almost universal, but not entirely universal, then the average person is going to use his phone for accessing more health apps like Apple Health, etc., Fitbits linking to their phones, etc. But also there are access to very useful mental health apps for things like CBT. There's a fantastic website called Kooth, which is tailored to adolescents and young adults with mental health problems. And what's interesting with that is the data shows that there's a great use by the Black and Asian and other ethnic minorities who would normally not be seen in surgery with mental health problems. And it's shown to be extremely successful and supportive. And obviously, patients are going to be using social media and get their information from that, and also from so-called medical influencers. Increasingly, patients will be able to put in their data on their smartphones, and it'll be sent to their GP system, like it's being started off with a System 1 computers using AirMid. But on top of that, patients are not going to just rely on general practice as a source of expert information. They'll be going to other sources. We've seen GP at Hand, which actually is based in Northwest London, in Hammersmith, and how successful that's been, partnering with Babylon. Says it uses artificial intelligence to help reach a diagnosis. There's the NHS app, which allows you to access your patient records and order pre-prescriptions and at the moment. And then there's the NHS apps library, which is a library of health apps that have been vetted by the NHS. Then, of course, there are other sites like Push Doctor and Now GP, etc., where patients can have one-off consultations. Then all this information will be sent to their own registered GP at some point. And coming to the end of the talk, I thought I'd show you a couple of videos of what's already going on and how this is going to affect general practice. And this is a video of what is currently being sold in the States prior to COVID to mothers with young children. and it's being sold at $199.
When your family is sick, you'll want all the information you can get, and as quickly as you can get it. That's why we created TytoHome, an innovative device that connects you with a clinician anytime, anywhere, even from home. To connect to the service, you'll need the Tyto app on your smartphone for a real-time video conference, and the Tyto device to conduct the remote exam. The device has an easy-to-use touchscreen that guides you through the examination process. You can conduct exams on the heart, lungs, ears, throat, skin, and body temperature. Let's see how it works. Emily has a cough, earache, and a fever. Her mother, Linda, requests a live examination with the clinician. The clinician can see and speak with Linda and Emily to guide them through the specific exams he'd like to perform. In this case, he examines her ears, throat, and lungs. Results appear instantly on the clinician's screen so that he can listen to and see the exam results in real time. Having diagnosed an ear infection, the clinician digitally submits Emily's prescription to the pharmacy for pickup. He can also send a referral for a specialist, as well as keep the test results in Emily's records for future reference.
So if you think that can only happen in the States, many of you will have seen this video that came from the Sheba Medical Center, and they were using the same software to remotely monitor patients who had COVID.
שלום, מדברת דוקטור ברקאי מיחידת אשפוזי הבית של שיבא. השארתי לך ליד הדלת ערכת אשפוז בית, כל הציוד שנדרש לך.
שלום אורה, מה שלומך?
יכול להיות יותר טוב?
אני דוקטור סגל, מהיחידה לאשפוזי בית של תל השומר, ואנחנו נפגשים עכשיו במסגרת המעקב אחרייך כחלק מקבוצת האנשים שיש להם קורונה. אני רוצה ברשותך למדוד לך את חום הגוף. אם תיקחי לרגע את הטייטו, את המכשיר הקטן הזה, את תוכלי לראות שעכשיו אני מדליק עליו.
I'm told you're not seeing the video, you're just hearing it. Is that right, David?
We're not seeing the video.
Okay, I'm not quite sure why that's happening.
Is
okay.
there anywhere you need to click on the video?
I don't think so, no. Let's have a quick look and see. It's just not picking up.
It's not going. If you go on to the next slide and then come back to that and see whether something else comes up.
You seeing the? Are you seeing the slides now?
We can see the Sheba slide. What about pressing on this arrow here?
Can you see this or not? Still not see it?
Right.
Can't see it yet.
I can just see the initial slide.
Okay, I think we'll have to skip over that then.
Sorry.
It's a great shame. Never mind. It's one of these technical things. Zoom clearly has a problem with linking it up with the internet.
Yeah.
Although it's coming through on my slide, so on my screen, so I'm not quite sure why that's the case. But anyway, so let's move forward and forward. So this is another video I was going to show you. In fact, what the next stage is. This is a piece of kit that is in prototype at the moment that can diagnose 13 different conditions and monitor. And if you think this is science fiction, actually, it's just the start. It's just the beginning of the way things are going to go. And what we as GPs and general physicians will have to adapt to, because the data and the pictures from this sort of kit is going to be sent to us in increasing quantities. And already you can get attachments for your smartphone for a dermatoscope, and you can use that to either interpret yourself or send to the dermatologist for an opinion. It's quite common for smartphones to be attached to blood pressure cuffs nowadays, and they're doing that increasingly for remote monitoring in care homes. You can get an ultrasound attachment, and again, this is being sold particularly in America for first-time mums, so they can scan their baby and send the images to their obstetrician. But increasingly, I think we as GPs will have to understand and interpret these sort of handheld devices. And ultrasound is a particularly useful skill to be able to learn, and it's actually one of the core skills on many American medical school curriculum, and increasingly in continental Europe. Welsh Allen produce some nice attachments, so you can turn your iPhone into a digital eye camera and get retinal screening and retinal photography, as well as slit lamp views. And finally, there's wearable technology, and we see this increasingly in the use of sport, where we can track how fast footballers, how far they've gone, how many passes they've made, how many shots, all using GPS technology. And increasingly, people are looking at what sort of clothes can be adapted to have various sensors on, and these sent for monitoring. So in summary, will this lead to new GP skills? Well, it should lead to an overhaul of vocational training, which I think is long overdue. And I think we'll see these skills being put on the curriculum for vocational training in general practice. In particular, remote and virtual consulting skills will be expected to do more diagnostics with point of care kits, not just blood glucose and cholesterol, but increasingly there'll be very many other uses of point of care testing. We've talked about ultrasound, and primary care networks will probably be shortly putting ultrasound machines in their centres. We've talked about dermatoscopy skills and ophthalmology skills, but increasingly we will be the curators of patients' health data, and will be the conductors of what we do with this data and how we can best manage our patients for the future. So I hope this is food for thought. I apologize for the fact that Zoom wouldn't show you the videos, but I hope this has given you a glimpse of how general practice will change over the next few years. Thank you very much.
Thank you very much for that. We did see the first video.
Oh, right, okay.
It was only the first video was seen very well, and it was only the second one we didn't manage to see.
That's very strange.
We've already, unless it's something to do with the, I was actually kind of unaware, because I was listening to the Hebrew and was following the Hebrew. So, thank you very much. And now we've got a couple of questions already that have come in. Mm-hmm. The one is, the practice influence the growth of digital health. How the impact on the previous practice, you've already addressed quite a lot. What about social care? Does it also have an impact on social care, that this kind of change?
Increasingly, I think the first way it's impacting, it's already happening. Many people don't realize, but a lot of local authorities are giving out telemonitoring kit for, particularly for patients with dementia. So they're often issued with GPS bracelets. So if they go wandering, they can be tracked. There are sensors on in the house. If the fridge isn't opened for 6 hours, alarms are called. So increasingly social services, in fact, in many ways, they're ahead of us in many of the kit they use, because more than the NHS, they're driven by costs and cost savings. So they've invested quite a bit in digital technology, particularly for the elderly and for the frail.
The question then raised is, how does an anxious elderly person with no computer skills and no smartphone speak to a GP? That's
yes. So I think increasingly those patients will be identified. I think almost every practice knows which cohort of patients will not be able to cope with the new technologies, and they will adapt so that they can carry on accessing it in the old way. By and large, these patients will be ones who are well known to the practice because of their age or frailty. They'll be known to other services like community services as well as social services. And so I think what will happen, and it's happening already with the PCNs, is we have what we call huddles, where once a week some of the GPs, the district nurse matron, and increasingly a social service person will get together and we'll discuss these patients, particularly ones in need, and they'll be the ones who'll be visited on a more regular basis because they can't be accessed digitally yet.
What is going to be the impact of this on medical education, and both for medical students and in postgraduate training, if patients are only in virtual clinics, for example?
I think that's interesting. I think it's a great shame that whereas when I started off in general practice, the NHS and general practitioners were at the forefront of digital technology, and I have many GP friends who went away and wrote their own software. We're now at the back of technology compared with other countries in the world. And so I don't think our curriculum has caught up with the needs for this. I think what COVID has done and will do will emphasize the need to focus on how we interact better with patients remotely, how to look at those hidden non-verbal signs, because on a face-to-face consultation, there is so much more information being given out by the patient than just verbally. How we pick those up is going to be interesting. And I suppose in time, that there'll be software that will pick up these cues to support the GP. That's a bit more in the future. But again, that's where both the undergraduate and the postgraduate curriculum needs to take off. I don't think there's a great deal in the undergraduate curriculum yet about remote consulting. They have to get the basics done first, but in time, part of that basic will be consulting in a virtual and remote way.
The one question that leads on from that is that basic medical teaching is take history, then examine. That's the way medical students are taught. And even if you have, for example, blood tests and imaging done beforehand on everybody, how do you get around this question of, the next step is to examine?
Yeah, so at the moment you can't, and I think what we're seeing now in the post-COVID lull is that quite a few of those patients who we were able to put off by doing blood tests and things and seeing what was going on, there are still a lot of conditions where you just have to place your hand on them to examine. I suppose if you're really future gazing, you would say that the sort of virtual and artificial reality or an augmented reality kit will come into its own there. And you saw that a bit. I think Imperial were experimenting with the IBM HoloLens, where the consultant would go into the bay of a patient with COVID with his COVID lens, with his HoloLens on, which would allow that consultant not only to pull up on his HoloLens screen all the charts and medication, but allow other people who weren't in that bay to experience the same experience that that consultant was getting. And in time, the virtual reality kit will become more universal. And I suspect in 30 years' time, that's what we'll be using for many consultations that are remote. And we're already seeing remote robotics for some operations, and that's being tried by the military, because it can be very expensive if you're in the Navy and someone has some sort of medical emergency that needs an operation. They're using remote robotics increasingly to do some of the operations there.
Right. We've got one raised hand which I've been unable to access, and Alan Salama, I've unmuted by some miracle of technology. Alan. Alan.
I think that might have been a mistake. I'm terribly sorry.
It's okay.
Yeah.
Well, there's another question that's come up over here, which it seems that COVID-19 has decimated new possible cancer referrals. How will this be addressed?
Well, I think that's something that we are still struggling. I don't think technology's got the answer to that. I think it was a mixture of closing shop for routines on the NHS, but also fear of the patients that they would pick up COVID if they went to a medical establishment. The backlog is huge. The diagnostics aren't readily available to catch up with all the backlog for two reasons. One is there's a physical backlog, but two, because of our worry about keeping patients clear of COVID, we can't see as many patients and do scans at the same rate we did. We can't pack them into waiting rooms, and we can't schedule them at the same rate. There's no really quick answer to that, and I think that there's going to be a lot of fallout.
I think that we've really actually we've got more than our money's worth, if you like, from today. And I just want to express everybody's thanks to you for a really fascinating tour, put so clearly about what's happened and what the impact of that is going to be on medical practice. And it's indeed as big as people tell us. And you've been a wonderful exponent of it. So thank you very much.
Thank you very much for inviting me.